Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. I didn't learn about IgG4-related disease until later in my rheumatology fellowship. I remember seeing an elderly male that had a diagnosis of recurrent autoimmune pancreatitis that was steroid dependent, so that every time his doctors tried to wean his steroids, his disease would flare, and he would present again to the hospital with worsening abdominal pain, features of pancreatitis, and weight loss. The gastroenterologist that was managing his case wanted to know whether there were any steroid-sparing agents that could be added to help manage his disease. When reviewing his chart, I remember seeing that he had evidence of retroperitoneal fibrosis on a prior CT scan. And eventually, when I checked it, he had elevated serum IgG4 levels. Almost a decade on, IgG4-related disease has firmly established its presence in the medical community. There's been a huge surge in literature on the topic, including articles, book chapters in both rheumatology and internal medicine textbooks. There's even been the establishment of ACR-EULAR classification criteria for IgG4-related disease. The pathophysiology is now much better understood, and global clinical trials are now underway. Much of this progress can be attributed to the tireless contributions of just one person, Dr. John Stone. In today's episode, we've invited Dr. Stone to share his insights about IgG4-related disease, including the clinical presentation, how to make the diagnosis, the symptoms that patients experience with the disease, what's happening inside the body, the role of IgG4, treatment options, and the research that he's currently leading to identify even better management solutions. He also sheds light on his personal journey in the field, and he highlights the significance of the work that's being done. Dr. Stone is professor of medicine at Harvard Medical School and the Edward A. Fox Chair in Medicine at Massachusetts General Hospital. He co-founded the Vasculitis Center at Johns Hopkins and directed a now famous multi-center randomized clinical trial in GPA. And of course, the results of this trial were published in the New England Journal as the monumental RAVE trial in 2005. His most current research interest actually pertains to IgG4-related disease, and his research group at MGH made the seminal observation that rituximab therapy leads to the reduction of IgG4 in this disorder. As you'll hear, this really is a masterclass on IgG4-related disease from one of the leading figures in the field. I really hope you enjoy it. John, welcome to the show.
Thank you, John. Thank you for the invitation. Looking forward to our discussion.
How did you become interested in IgG4-related diseases of all things?
Well, I can tell you the exact day that I became involved in this. It was my very first patient whom I knowingly saw with IgG4-related disease. I think I'd missed a lot up until that time.
Yes.
It was one of the very first patients I saw upon coming to MGH in 2008. One of the very first patients I saw in clinic was a 26-year-old woman from Casablanca, always my favorite movie of all time, for what that's worth. 26-year-old woman from Casablanca referred to me to rule out Sjogren's syndrome. And she had these walnut-sized swellings under her chin. That case really caused my career to take a major deviation. And over the past 15 years, I have spent an increasing majority of my time studying this fascinating condition. So that was the very first patient. And I'll tell you a little bit more about that. I presented her to our colleagues at MGH. I didn't know what she had. I didn't think she had Sjogren's because I'd never seen Sjogren's look like that before. And my colleagues convinced me that, well, if she's got Sjogren's, she could actually have a lymphoma.
Mm-hmm.
You probably should biopsy one of those. those submandibular glands. And so we did. The ENT to whom I sent the patient removed the entire gland, which surprised me a little bit. And then the pathologist didn't read out the case for about 2 weeks. So finally, I went by the pathology lab myself and I sat down at the microscope with the patient. And the pathologist said, "This is the craziest case. It looks like she has autoimmune pancreatitis in her submandibular gland."
Wow.
And that was the first inkling I had that maybe I was dealing with a multi-organ disease. And then, long story short, once I became aware of this, the Japanese had actually described this disease about 5 years before, but they had written about it only in the Japanese literature, and virtually nobody in the West knew anything about it. Once we became aware of it at MGH, patients just started to come out of the woodwork. The pathologist would send us patients of pancreatectomy samples
Wow.
of patients who thought they had undergone Whipple procedures because it was thought they had pancreatic cancer. And we realized we were following patients in our clinic who had IgG4-related disease, and we thought they'd had Sjogren's or lupus or something else like that. So that's how it all started.
Fascinating. So when you started sort of piecing together that puzzle, what was known about IgG4 related disease? Anything? Or is it just that some of those stories from the Japanese that sort of tied this together as a systemic disease?
When I started reading about what my patient might have, there were 2 papers that I couldn't find. One was from 1892 from
Wow.
the German literature. And I had to go across town to the Countway Medical Library to find this paper, which had been written by one of the most famous surgeons of the day, Johannes Miklich, who described a 44-year-old German farmer who had a patient who looked very much like my patient, swollen submandibular glands, parotids, and lacrimal glands. For years, people had referred to Miklich disease or Miklich syndrome, but 2 things happened. In the year 2001, Japanese investigators published in the New England Journal of Medicine the finding that patients with what they called sclerosing pancreatitis had elevated serum IgG4 concentrations. New England Journal of Medicine publication.
Wow.
And then only 2 years later, well, it took 2 years later to publish the fact, again, Japanese investigators, that patients with sclerosing pancreatitis, which we now call autoimmune pancreatitis type 1, also had IgG4 positive plasma cells, not only in the pancreas, but in other organs, multiple other organs. So that was what was known about the disease, basically. And at that time, it was really thought that IgG4 caused the disease. And many of the organs that we now know to be associated with IgG4-related disease hadn't even been described yet. So it was really a remarkable era of discovery for us, because we would see a patient who had aortitis, and lo and behold, at surgery, the aorta looked just like IgG4-related disease. And then we would review the patient and find the patient had a history of submandibular gland enlargement, autoimmune pancreatitis, etc.
Wow.
So it was putting together all of these things, and very little was known in 2008. It still was all phenomenology, essentially.
What an incredible story. And what a privilege to be able to put those pieces together in the puzzle. That, I'm sure, to most of us, that will never happen.
Privilege is the word that I always use.
Privilege.
Privilege, because it has been a true privilege to participate in the description of this and to be able to help patients, direct them in the right way, and find new treatments for it.
Amazing. And what is it about Japan? Because you're huge collaborators with you in IgG4 related disease. Is it particularly common to the Japanese population, or is it that they just were able to identify this earlier than other countries?
I think it's the latter. They simply identified it first. In a country that is more diverse in terms of its population, like the United States, we see patients from all over the world with this condition. So we see it in African Americans, Hispanics, people from the Indian subcontinent, and in Caucasians as well as Asians. There are some interesting little points that need explanation. There's a lot we still don't understand. But one of the intriguing things is that we looked at serum IgG4 concentrations in patients at our hospital a few years ago, when we found that Asians have higher baseline concentrations of
Oh, interesting.
IgG4 than Caucasians and African Americans and other ethnic groups. So I don't know precisely how to interpret that yet, but long answer short, I don't think that the disease is more prevalent among Japanese or among Asians in general. It is a worldwide disease.
Got it. So, with everything that you've learned about the disease so far, are there commonalities about how IgG4 related disease typically presents? Like, what should we rheumatologists be looking out for, and what should patients be looking out for if they may have this condition?
It's a remarkably protean disease, but it can boil down into a few really important take-home lessons. Now, rheumatologists are most likely to see a patient like I saw. They're likely to see patients with head and neck disease because these patients are going to be referred to us to rule out Sjogren's syndrome. So the Mikulicz-like presentation of submandibular gland, parotid, and lacrimal gland enlargement, very typical, probably the thing that rheumatologists are going to see the most. Orbital disease is also a very prominent component of IgG4-related disease, and it doesn't necessarily segregate with the Mikulicz disease. It can occur, orbital disease can occur in isolation, and rheumatologists might see that too. The orbital disease can be caused by disease in a number of areas around the eye, particularly the extraocular muscles. For years, the ophthalmologists would refer patients to me who they thought had IOI, or idiopathic orbital inflammation, or orbital myositis. Turns out that I think most of those patients actually have IgG4-related disease.
Crazy.
And sometimes these patients can present with a mass behind the eye, a retrobulbar pseudotumor. And earlier in my career, I saw lots of patients who I thought had granulomatosis with polyangiitis with that manifestation. I think some of them probably had IgG4-related disease. So that's what a rheumatologist is likely to see. Another presentation a rheumatologist is going to see a lot is an elevated serum IgG4 concentration. And the question, does this patient have IgG4-related disease, is sort of the fashionable new positive ANA.
Love that. For better, for worse.
Yeah. So something else that rheumatologists will see. And I think an important take home about how IgG4-related disease presents is it very often presents with a mass lesion. So patients are thought to have a malignancy. Once the tissue has been biopsied and it turns out not to be a malignancy, then the patient is likely to be sent to a rheumatologist.
Got it. And from a patient perspective, when they have these masses, whether head and neck, pancreas, surrounding the aorta, what symptoms do these masses produce, if any?
So that's a great question, if any, because IgG4-related disease can be a remarkably asymptomatic disease. So Japanese colleagues have described a wonderful metaphor for the disease. They've described it as being like a dark crow flying through the night, because when you were in medical school, the disease was there. When I was in medical school, the disease was there. We missed it, and all of our professors missed it, and it was there for generations before and much longer. And so patients can have very few symptoms despite having multi-organ disease. Now, if the mass is in an inconvenient place, like the head of the pancreas, then they may present with painless jaundice and be misdiagnosed as having pancreatic cancer. And they may come to be diagnosed earlier. But very often patients, I guess my point is, they don't have systemic symptoms.
Got it.
Quite often having multi-organ disease.
Got it. So they have these sort of painless masses in various places, but not necessarily have fevers, weight loss, night sweats, things like that.
The reason patients with IgG4 develop weight loss, it took me years, I'm embarrassed to admit it, the reason they lose weight is because they have suffered exocrine pancreatic failure. Because of involvement of the pancreas no longer makes digestive enzymes. They can't digest foods, they can't absorb calories and nutrition, and they lose weight. I've had patients who've lost 50 or 60 pounds.
Wow.
But their sedimentation rate or the C-reactive protein is normal. It's not associated with the systemic inflammatory response that we think about in vasculitis or lupus or something like that.
What is actually happening in these organs? What is driving the collection of these IgG positive cells into these organs? What have we learned over the last 15 years about the pathophysiology of IgG4 related disease?
We've been very fortunate to collaborate with some wonderful immunologists at MGH and at the Raygon Institute, which is part of MGH in Cambridge. And we've been able to piece together a fairly complete pathophysiologic scheme. We believe that the disease is an autoimmune disease. And it's interesting, and this autoimmune disease tends to affect males a lot more commonly than females, but we think it's an autoimmune disease. We have not identified a single antigen that seems to be the target. Different labs across the world have identified more than one antigen so far. And we believe that the major players in this are cells of the B lineage, and there are a variety of cells of B cell subsets that are playing an antigen presentation role to cells of the T lineage, particularly a CD4 positive cytotoxic T cell that has a marker on its surface called SLAMF7. And our group was the first to describe SLAMF7 on the presence of this CD4 positive T cell. We also know that CD8 positive T cells play a role in the disease. So cells of the B lineage presenting antigen to these two kinds of T cells. That's the key cellular interaction. But it's clear that it's really a symphony of inflammation, and T follicular helper cells play an important role. Those are the cells that drive the class switch to IgG4. Macrophages play an important role. Eosinophils are present both at sites of disease and in the peripheral blood. So it's like most complicated autoimmune diseases, it's complicated. In cancer, there's one cell. I don't want to be simplistic, but there's one cell that's aberrant in cancer. It's the one that's malignant, it's proliferating. In IgG4-related disease and in rheumatoid arthritis and in ANCA-associated vasculitis and in Sjogren's syndrome, there are more players on the field, so it's more complicated.
Are there specific risk factors for the development of IgG4 related disease, whether it's genetic or environmental?
Let's talk first about the epidemiology of the disease. It can occur in every people of all races and ethnicities. It can occur throughout the age span.
Children?
Well. There are children with classic cases. One of the most classic cases I've ever seen is a 16-year-old boy.
Wow.
And it's been described in younger kids too. But the typical patient is a middle-aged to elderly male. And males seem to have twice the risk of getting IgG4-related disease than females do. That's not to say that females can't get disease that is every bit as bad and as extensive as males. But in our cohort at MGH and in every other cohort in the world that I'm aware of, males tend to outnumber females by about 2 to 1. We have no idea why that's the case. In terms of genetic risk factors, the genetic studies, GWASs, et cetera, are really still in their infancy. The Japanese did a GWAS about 5 years ago, but it only had about 900 patients with IgG4-related disease.
Only 900? That sounds like a lot.
Yeah, that's small as GWAS studies.
For GWAS, yeah.
Yeah, I mean, 9,000, and I'm sure we would have identified some additional risk factors. So we don't know too much about the genetics yet. I will say that familial cases are rare. We have had a few, so they do occur. And I'm sure genes play a role in it in some way, but it's not been well studied yet. In terms of genetic risk factors, other exposures other than genes, cigarette smoking has been shown to be associated with retroperitoneal fibrosis. Maybe that has something to do with a male predisposition, with males more likely to smoke in some societies than others. I don't know. I think there's more to it. So there's still a lot to be learned about.
And the IgG4 cells, what are they doing there? Why is the serum IgG4 levels often elevated? And what are these cells doing in the organs?
Initially, when I became aware of the disease, it was thought that IgG4 caused the disease. We think that's not true. I think that the best analogy for IgG4, the antibody, and its relationship to the disease is the relationship of fire trucks to fires. If you look at fires, there are fire trucks all over the place, and you might conclude erroneously that fire trucks cause fires. We think that IgG4 is like a fire truck. It's trying to put the fire out. It's a non-inflammatory antibody, at least in many cases, and we think that's the case here. And it doesn't activate complement well. It doesn't bind antigen tightly. And we think that it's playing a counter-regulatory role, maybe trying to go into areas of inflammation, bind up loose antigen, and just dampen the process. And it's failing to do so. So the IgG4 rises in the concentration until such time as an effective therapy is administered. And then give the patient prednisone, give the patient B-cell depletion, and then the IgG4 concentration falls. That's how we envision the role of IgG4 at the moment, not as a primary cause of the disease, but as a failing response mechanism.
Interesting. Yeah. So bringing it back to the clinic, let's say we have a patient with a mass that we maybe suspect IgG4-related disease. How should we go about making a diagnosis of IgG4?
So if you see a patient with Mikulicz involvement of the organs, with classic lacrimal gland, parotid, and submandibular gland, and you've seen that a time or two, then if the patient has an elevated serum IgG4 concentration, or even if they don't, frankly, you can be confident that that's the diagnosis. I don't think that patient needs a biopsy.
Got it.
Once you have seen this a lot of times, you can be comfortable that this is IgG4-related disease. This is not lymphoma. This is not sarcoidosis or something else like that. We approach the diagnosis just like a good rheumatologist approaches every diagnosis. We talk about the clinical information, meaning the history and the physical examination. We think about, what do the serological features tell us? Is the serum IgG4 high? Is the IgE high? We see that a lot in IgG4-related disease. A third of patients with IgG4-related disease have low complement levels. So that's a helpful finding also. So what do we see serologically? Is the ANCA negative? It's important to have a negative ANCA. It's important to have a row in the law, a negative row in law, if the patient has a presentation mimicking Sjogren's. So clinical, serological, radiological, particularly the speed of progression of any radiologic lesion. IgG4-related disease is an indolent disease. It progresses very slowly. If you've got changes on chest X-ray or in the head and neck on a CT or MRI that are evolving fast, that's almost certainly not IgG4-related disease. And then finally, the pathology. There is no diagnostic pathology of IgG4-related disease. The pathologists do not have the final word. Clinicians do. We have to put together information from the clinical features, serological findings, radiology evidence, and the pathology to determine whether the patient has IgG4-related disease.
Got it. So in most cases, you think a pathology is probably required or beneficial, unless those classic cases?
I think that it is very helpful in providing reassurance. An absolutely classic presentation with a serum IgG4 concentration elevated to 15 times the upper limit of normal. It's usually wise to get a biopsy if there is an easily accessible organ. Sometimes the patients come to us with the biopsy already because it was thought that they had cancer and they had the biopsy for that purpose.
So in terms of thinking about the differential diagnosis and things that patients may have been diagnosed with, you mentioned malignancy, Sjogren's, ANCA-associated vasculitis, sarcoidosis.
All of those. Yeah, those are probably the top 4 out of my mouth every time. Other things that can occur, one has to think about the histiocytoses, things like Erdheim-Chester disease and Rosé-Dorfman. The only way to make those diagnoses is to biopsy patients. But one has to keep those in mind as well. We've seen IgG4-related disease look very much like lupus. I've seen very good renal pathologists fooled by thinking that a kidney biopsy was lupus nephritis. But when you think about who the patient was, the patient is an 80-year-old Chinese man, not a typical de novo onset lupus patient. So you have to put the whole thing together. So lupus is also in the differential diagnosis.
Fascinating. A few years ago, you published classification criteria. How should we think about classification criteria in terms of the clinic, if at all, or is that just for research purposes?
It's been pounded into my head that classification criteria are not diagnostic criteria. And the exercise of helping to develop the classification criteria drove that point home. They are not diagnostic criteria. In that, a patient may actually have IgG4-related disease, and you may really think that they do, but for whatever reason, they're not going to fulfill the classification criteria. Very often, that's because you can't get a biopsy, and that's what they really need. A patient with retroperitoneal fibrosis with inflammation around the aorta, no radiologist is going to want to biopsy that. They typically don't have elevated serum IgG4 concentrations, and I think that patient has IgG4-related disease. If we had a surgical biopsy, we would prove it, but we don't.
Got it.
The patient has a clinical diagnosis of IgG4-related disease, but cannot be classified as IgG4-related disease. Having said that, classification criteria are not diagnostic, these classification criteria are still very useful to me when I am evaluating a patient. And I think, well, would this patient fulfill classification criteria or not? If they don't, I think that should raise a level of doubt in one's mind. Why don't they fulfill it? Is it simply because you don't have a biopsy and can't get a biopsy? Or is there something else that should make you reconsider the diagnosis? So I think they're very important, but they'll never be classification. They'll never be diagnostic criteria.
So as a rheumatologist, I should be familiar with it, thinking about whether my patient may classify as having IgG4-related disease, but not necessarily hold it as a standard for diagnosis.
Yep.
That makes a lot of sense.
Yeah. The exercise of going through the clinical features, serological findings, radiological evidence, and pathology is available. That's very helpful to us, not only in IgG4-related disease, in so many diseases. That's our approach.
I often think about it as a checklist, right? Like to make sure that you're not missing anything, like checking an ANCA, right? Maybe you're so focused into the of anchoring on the diagnosis of IgG4-related disease that maybe you forget about checking the ANCA, and reviewing the classification criteria says, maybe I should do that.
Once or twice a month, we refer a patient with IgG4-related disease, and it turns out to be granulomatosis with polyangioma. And the opposite is true too. So ANCA-associated vasculitis, particularly GPA, is a huge mimicker of IgG4-related disease, and vice versa.
Okay. So once we make the diagnosis of IgG4-related disease, how do you think about treatment for these patients?
We've learned a lot about treatment, and we're now finishing one clinical trial, multi-center worldwide clinical trial. We'll be finishing an evaluation of an anti-CD19 therapy for the treatment of this disease. And I hope that that therapy will be the first drug approved for this disease across the world. Early on, we were fortunate to discover that anti-CD20, also targeting B cells, is a very effective treatment for IgG4-related disease. We were never able to convince the company that made the anti-CD20 to do a worldwide trial and get the drug approved. But B-cell depletion is a very effective therapy. For patients who have multi-organ disease and very elevated serum IgG4 concentration, those patients, they will not be put into a long-term remission with a short course of steroids, no matter what dose you start with. If steroids are going to get them into remission, then you're going to have to maintain remission. You're going to have to keep the patient on steroids. Mm-hmm. And because of the organ targeting of IgG4-related disease, and because the demographics of the disease occurring in middle-aged to elderly males and targeting the pancreas, steroids are usually the worst possible therapy to have to use in these patients. Yet, across the world, glucocorticoids are the treatment of choice. Even in the United States, 85% of patients are treated initially with steroids or only with steroids. Very often, practitioners in the United States aren't aware of the efficacy of B-cell depletion. Clinicians in other parts of the world don't have access to B-cell depletion. So patients are treated with steroids with all of the predictable complications of those. So sometimes I start steroids first if it's limited disease.
Okay.
And I hope that maybe a couple of months of steroids will lead to a long-term remission, or at least a few months. And then if they flare, then I would look for a more definitive B-cell depletion approach. In the future, we may be able to use something else earlier.
People with systemic disease, it's sort of anti-B cell treatment right off the bat. People that have more limited disease, maybe a trial of steroids, but still thinking if it recurs to put him on B-cell depletion therapy. And when you start somebody on B-cell depletion therapy, do you also use steroids in addition, or just...
So all patients who get rituximab get 100 milligrams of methylprednisolone with each
as
dose.
the infusion, that's right.
So it's hard to know how much of the swift response is due to B-cell depletion and how much is due to the methylprednisolone. Really impossible to know. There are other B-cell targeting therapies that are not B-cell depleting. A medication called obexelimab is now also in worldwide clinical trial. So there are other strategies as well. And in the era of COVID, which I regret to say we're not quite over yet completely, using B-cell depletion requires a discussion.
That's a good point. Just to clarify, in people with systemic disease, with IgG4-related disease, who are putting on B-cell depletion, you're not giving them oral steroids.
I very often do not, because B-cell depletion works so well. Ultimately, this anti-CD19 therapy that gets approved, it'll be interesting to see if it gets approved. We'll have to see what the label shows. I don't think it's a problem most of the time to use a short course of prednisone at the beginning. Sometimes you have to monitor the blood sugar carefully, but once it's clear that the patient is responding, you can taper it off very quickly.
Got it. So can IgG4-related disease be cured, or what happens to these patients over time?
Like other autoimmune diseases, IgG4-related disease is presently not curable with our current therapies. We are able to put patients into long-term disease remissions in which maintenance therapy is required, intermittently anyway, but we don't cure it. I do think that we don't know enough about the natural history of treated patients. My sense is that repeated rounds of B-cell depletion lead to longer remissions. So eventually we could space it out. I often do this in ANCA-associated vasculitis. I might give patient a consolidating dose of rituximab at 4 months and then space the rituximab out so that I'm giving patients one dose of rituximab once a year, for example. And in IgG4-related disease, I think they may not even need to be treated that often, because sometimes patients can go for a couple of years without having evidence of disease recurrence.
So how should we monitor these patients to see if they have evidence of disease recurrence? Is it measuring the serum IgG4 levels? Is it the physical exam, the history?
Well, here's another real advantage. We are always moaning in rheumatology about how we don't have good biomarkers. But IgG4 is a good biomarker.
Ah, okay.
The higher it is at presentation, the better it's going to be as a biomarker. If you think the patient's got IgG4-related disease and you treat them with B-cell depletion or steroids, and they don't have a prompt drop in their IgG4, you better reconsider the diagnosis. The IgG4 concentration doesn't normalize quickly, but it comes down substantially pretty quickly. And it will continue to decline for many months as long as the disease is under control. It's long-lived plasma cells that have migrated back to the bone marrow that continue to make IgG4 for a long time. And that's why the IgG4 doesn't normalize completely. But when it starts to go up again, then that patient, I think, to me, that means the patient has active disease somewhere. Not clinically evident yet, but you should think about retreating the patient.
Got it. You mentioned at the beginning, we're getting referred these patients with elevated IgG4 levels who may or may not have IgG4-related disease. So what's on your differential diagnosis of those patients? What else causes elevated
Oh,
IgG4
it's very
levels?
broad, very broad. So here's something worth keeping in mind. Nice paper published recently by Matt Baker and Zach Wallace, a collaboration between our group and Stanford, found that among patients with a serum IgG4 concentration more than 5 times the upper limit of normal, so really, really high, 1 in 4 of those patients has another diagnosis. So allergic manifestations, atopy is something that we don't really understand very well in IgG4-related disease. A lot of our patients have it. A lot of patients who are atopic, who have asthma and don't have IgG4-related disease, can have an elevated serum IgG4 concentration. Patients, there are lots of different other rheumatic diseases that can have at least a mild to moderate serum IgG4 concentration. So the list of diseases that can do that is literally dozens.
Seeing it as sort of as a rheumatoid factor in that it is sort of sensitive but not necessarily specific for rheumatoid arthritis.
Right, that's right. So,
okay.
Yeah, I mean, greater than 5 times the upper limit of normal has a positive predictive value of only 75%. The higher it is, if you tell me it's 15 times the upper limit of normal, I would say it's probably, almost certainly, IgG4-related disease. But tell me a little bit more about the patient's claim.
Love it. So you've been doing this work for 15 years. Are there questions that you still have? Where's the research headed over the next 5 to 10 years?
Oh, a ton of questions. Yeah. And I feel like the answers are within our reach, actually.
Okay.
Within the next 10 years, I think we're going to be able to really answer a lot of important questions about this disease. So one of them relates to antigen and what antigen or antigens are triggering the disease. We and other labs in the world have identified 4 or 5 antigens that one can make reasonable stories for. But these labs have used different techniques. Most of them have focused on identifying antigens seen by B cells, and very few of these have been validated by other labs. So we don't know whether galectin-3 is really an antigen that can trigger IgG4-related diseases as we've described in our lab. A third of patients in our cohort have anti-galectin-3 antibodies. That work needs to be validated by others, and some of the other antibody work done by other labs needs to be validated by other labs. We're only beginning to approach what antigens the T cells see, the CD4 and CD8 positive cytotoxic T cells. Are they seeing the same antigen or different part of antigen that the B cells are seeing? And are T follicular helper cells seeing the same antigen, or is it yet another antigen? So there's some really very important fundamental things about the immunology that I think IgG4-related disease, those of us investigating IgG4-related disease can address, and we can learn a lot that's important for human immunology in general. This is a great disease to study because it moves slowly, so you can give a targeted therapy and then observe what happens to the rest of the immune system. Moving beyond the basic science, we need to understand better, as shortly we will have good non-steroid treatments for this disease approved. So we're going to need to learn how to use those in the appropriate way in practice. Is B-cell depletion or other B-cell therapy approaches, whether or not they deplete B-cells, do they need to be given continuously? Or can they be given for a while and then have the patient have a treatment holiday and then retreat patients when there are serological markers of disease recurrence? We have a lot to learn about how that goes. We have no idea why males are twice as likely as females to get the disease. That's fascinating. I can't think of a single other autoimmune disease where that's the case. So maybe we need to reconsider whether IgG4-related disease even is an autoimmune disease. So we've learned a lot, but there's still an awful lot to learn.
Do you think that our understanding of IgG4-related disease has helped us to better understand sort of inflammation or the immune system? Has it shed light in other ways?
Unquestionably. And I think it is just starting to do so. I think it underscores more strongly than just about any other disease, the relationship, the impact that B cell suppression or depletion has on T cells. That interconnectedness is demonstrated so vividly by what happens to a patient with IgG4-related disease who gets B cell depletion therapy.
Fascinating. I've been wondering, you spent sort of the first half of your career thinking about GPA and vasculitis. And now this part, you're sort of switching focus a little bit to IgG4 related disease and have had incredible success in both fields. What do you attribute that to? You mentioned before that it's sort of the privilege of doing that. It sounds to me that there's something about you that sort of made you incredibly successful in furthering two different fields together. How do you explain that?
Well, luck is is a big part of it. Luck is a big part of it. But as I made the transition to really focusing on IgG4-related disease, the thing that I think made it possible for me to really delve into it or predispose me to it is that vasculitis is all about pathology. If you're going to make the diagnosis of vasculitis, you've got to be looking at pathology. And I sort of took the same attitude to IgG4-related disease. And pathologists have taught me an awful lot about IgG4-related disease as well. And it was my tenacity in pursuing an understanding of what I was seeing in patients at the pathology level, which really opened my eyes to this whole new world of a disease. So I think it's tenacity is a really important thing, whether you're a clinical investigator or a laboratory investigator or a clinician or whatever.
Love it.
But luck has a lot to do with it too.
Well, what has been some of the most rewarding aspects of your work on IgG4 related disease?
I have said to many patients that it's one thing to participate in the identification of a new disease and the dissemination of knowledge about that. It's another thing to participate in the identification of a treatment. So we've been very fortunate to be describing a disease that's responsive to therapy. And if we can identify patients early enough, we can have a profound impact on their lives and prevent damage that would be life-altering otherwise. So it's wonderful to tell patients they don't have cancer, that I'm quite sure they don't have cancer, that they've got IgG4-related disease, and that it's treatable. And we know how to follow the disease and we can keep it away. That is wonderful. So being able to tell patients that is a real joy.
Fantastic. And where can physicians or patients learn more about IgG4 related disease? Certainly, this is not something I learned in medical school, and it's sort of more recently being more talked about. Are there online places that you would recommend for people to learn more?
I'm glad you asked me this question because this is one of the first public disclosures of the IgG Forward Foundation. IgG4 Word, exclamation point, Foundation.
Love it.
Which I have just founded. It will be announced at the ACR and at the 5th International Symposium on IgG4-Related Disease in Milan in April of 2024. And the IgG Forward Foundation, or just IgG Forward for short, is rapidly developing an outstanding website, which will be a great source to educate patients and clinicians and caregivers about IgG4-related disease. Because one of the most important lessons I've learned is that we can develop new therapies for the disease, but if we don't make the diagnosis early enough, patients are already quite damaged when they get to these new therapies. So our goal is to educate patients and physicians and other providers so that we can get to that diagnosis earlier and prevent these problems for patients.
Fantastic. And if you can share with us those links to your foundation, we can certainly put it on our podcast notes. John, this has been a really wonderful presentation and discussion about IgG4 related disease. I really admire your work and your tenacity, as you mentioned, in sort of pushing the field forward, and really wish you continued success in everything that you do. And thank you so much for your time and chatting with us today.
John, thank you very much for the invitation to do it. I've really enjoyed it and really appreciate the invitation.
Well, there you have it. That wraps up another episode of ACR On Air. Thanks again to Dr. Stone for sharing his knowledge and giving us a deep dive into the complexities and nuances of IgG4-related disease. For our listeners, if you want to learn more about this topic, we'll have resources and reference linked to the show notes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. If you enjoyed the show, please consider subscribing, rating, and leaving a review on your preferred podcast platform. It really helps us to reach more listeners to continue bringing you these invaluable conversations. Until next time, keep making the diagnosis of IgG4-related disease, and of course, stay healthy.